Good evening, everyone. This is Hussain Gharyadi, your host for this evening. Welcome to this webinar series, Advances in Neuroimaging, an Expert Talk Series. This is the third webinar that we have organized so far as part of this theme. Our topic for the day is current trends and role of artificial intelligence in stroke, CVG, TBI, which is traumatic brain injury, and surgical treatment for ischemic heart failure, which is STICH Trial. This webinar is put together by InMed Prognostic's Team NeuroShield in conjunction with GE Healthcare. And on their behalf, I warmly welcome you today. Without further ado, allow me to introduce you to Dr. Agarwal, our speaker for the day. Dr. Deepak Agarwal, an MBBS, MS, and MCH in neurosurgery. He's a specialist in gamma knife surgery, endoscopic and pediatric neurosurgery, computerization, hospital information systems, electronic medical records, and Vista EHR. He's an expert in stereotactic and image-guided neurosurgery on Medtronic Stealth Station, microneurosurgery, spinal instrumentation with particular expertise in CVG, cervical, dorsal, and lumbar instrumentation. Dr. Deepak has also been associated with the All India Institute of Medical Sciences, Delhi for the last 20 years, and currently serves as a professor of neurosurgery and gamma knife at AIIMS, and he's also in charge of the computerization, networking, and telemedicine at JPN Apex Trauma Center, AIIMS. He has also served as a clinical fellow in pediatric and endoscopic neurosurgery, Vancouver, Canada. Our panelist for the day is Dr. Ram Mohan, with a clinical radiology experience of 33 plus years. He's a senior consultant radiologist, global digital innovations at GE. He's a doctor in medicine, a PhD scholar in neuroimaging, and has authored 6 books in the imaging domain. He's a senior consultant radiologist at CVJ Diagnostics, Hyderabad. Ladies and gentlemen, before we start, a couple of things to note. All participants will remain muted during the presentation. We would request you to add your questions to the Q&A section. They will be addressed by Dr. Vadapalli and Dr. Agarwal at the end of the presentation. Thank you.
Hi, I am Professor Deepak Agarwal, in charge of the Neurotrauma Division at the All India Institute of Medical Sciences. And today I'll be talking on the role of AI and ML in neurosurgery. AI and ML in healthcare have been a success in waiting for the last few decades. And despite incredible research, algorithms for diagnosis and prognosis continue to be limited. In fact, there were more than 2,000 papers in 2020 alone on the role of AI and ML in diagnosing COVID using chest CT scans. However, none of these papers which were published were usable for actual clinical use. You heard it right, not a single one. And the answer is not far to find. There are flaws in data sets, like using the very same small data set across all the publications, using the same data set for training and testing, imbalanced data in terms of demographic statistics, and other issues. More than the flaws in data sets, there are flaws in analytics. And one of the biggest flaws is that disconnect with the radiologist and the subject matter experts. Also, there is a huge difference in the sample size for development algorithms. There is a risk of bias and a minimal inclusion of predictive features, which all leads to creating a model which is not good in predicting. One of the most important things we should ask ourselves is the problem we are trying to solve with AI really a problem? In the last example of COVID, which I talked about, why do we need to diagnose COVID with an X-ray or a CT scan? Why subject patient to radiation when there are simpler methods like molecular or clinical for diagnosing COVID. According to me, the real problem here would be prognosticating for late deterioration, and the research in COVID, especially in AI and ML, should be directed towards that. Neurosurgery is one of the most technologically intensive specialties with a huge potential of using AI and ML in improving care for patients. AI algorithms have been applied in neuroimaging to automate diagnosis of various neuropathologies, including stroke, TBI, and tumors. And it can maximize the accuracy of interventions while minimizing potential for collateral damage and post-op deficits. In neurotrauma, in fact, concussion has emerged as a leading cause for research as it affects young members of a society. From my side, the current problems to solve are emergency room automated head CT reporting, an objective assessment of hematoma, ventricular cisternal volumes, and midline shift in neurotrauma patients, automated comparisons over serial scans in these patients, and to rule out fracture or displacement at the craniovertebral junction. AI algorithms using machine learning can be used to automate reading and classification of neuroimaging data in neurotrauma, providing neurocritical patients with efficient diagnostic decisions. In fact, these data sets can be used to automate creation of the registries, including neurotrauma registry, which can be a huge boon to ensure correct diagnosis, follow-up, and management of these patients. Once we started using AI and ML in our patients with neurotrauma, we have created the largest TBI Head Ct database in the world, having 6,000 plus helical head CT scans. This is a prospectively collected database with each CT having a radiologist report which is digitized for future validation. And importantly, it includes the clinical data such as the admission GCS and the associated injuries which the patient has. Most importantly, it includes the outcome data of these patients, including the discharge GCS as well as the in-hospital mortality. These data are very important to properly train the models to be used when we try to have decisions for these kind of patients. In the near future, I see the possibility of having a dynamic score based on the current GCS of the patient along with the latest head CT finding, which will be displayed on the PACS viewer on inputting the GCS at the time of the head CT and will help in prognostic scoring of the patient. Ruling out a fracture or a dislocation in the occipital C1-C2 complex, which is also known as the CV junction complex, is a nightmare even for the most experienced neurosurgeons and radiologists. AI and ML have a huge role to play in this domain by ruling out or identifying CVJ fractures and dislocations. Auto rendering and showing the C1-C2 complex in 3D MIP, external and internal views, can also be a huge boon for the end users as well as the neurosurgeons. In the near future, I see AI and ML helping in auto labeling of the vertebra, orthopedical detection for auto trajectory and planning for various spine instrumentation procedures, as well as exporting into 3D printed CAD models for use in simulation, training, and actual treatment planning. Although stroke is the domain of neurologists, neurosurgery is intimately involved with the management of stroke. We do many a times decompressive cranectomy for large stroke volumes, as well as hematoma evacuation, as well as STMC bypass and other revascularization procedures in these patients. The big question to operate or not to operate in patients with intracerebral hematoma can also be helped with automatic hematoma volume calculation with surrogate markers of raised ICP. And these all can help in improved decision making. I think there are many pain points for the use of AI in ML. One of the most important is choosing the patients with good certainty of having a poor outcome with conservative management. And AI and ML can be really used in these situations. Many trials over the years, including STICH 1 and STICH 2 trials, have been done to actually find out a subset of patients which can be conservatively managed. However, till today, no positive indication has emerged on which subset to be used for actual surgery or conservative management. Again, AI and ML can be hugely helpful in these domains. To conclude, the future of neuroimaging is in AI and ML, and current identification of use cases and collaboration with the clinicians can improve the use of AI in routine decision making. AIIMS New Delhi, especially the neurosurgery department, has a unique collaboration among the 7 AIIMS across India for neurotrauma research. And we already have in pipeline 3 research projects where we can leverage each other's expertise as well as the volume of patients to really train the AI models to have higher efficiencies in prediction as well as decision making. Thank you so much.
How often do you use your brain? At this question most people chuckle or laugh. But the fact is we all use our brains all the time. Have you ever thought of your brain's health proactively? Almost never. Part of the reason is because we don't have reliable tools which will help us manage our brain's health. So, we at NeuroShield have come up with a solution where we offer cloud-based clinical decision support tool for neurological disorders. NeuroShield is an artificial intelligence and machine learning-based tool, helps neuroradiologists, neurophysicians and psychiatrists understand the brain better and offer evidence-based diagnostics. The current challenges, which are operational and clinical problems. All the existing solutions addressing these problems are expensive, time-consuming and don't provide contextual results based on age, ethnicity and gender. NeuroShield, the solution which combines the latest tools in medical and technological advancements. The common practice for doctors is to perform a neuropsychological assessment and ask for an MRI to help in diagnosing brain degenerative diseases like epilepsy and dementia. But visual MRI reading can many times provide non-conclusive information, resulting in misdiagnosis. Our software, NeuroShield, makes it possible to look clearly at the region of interest, like hippocampus, compute brain volumes, and supported by cutting-edge research and imaging analytics can help physicians reach more reliable and conclusive diagnosis conventional method. NeuroShield is the platform that aggregates insights from relevant modalities to provide holistic health and wellness insights. These are some snapshots of the platform provided with the test reports and volumetric analysis. Our competitive advantage matrix are as follows. Our vision is to bring affordable, accessible, reliable and evidence-based health prognostic tools in India and other emerging markets. Reach out to us and get to know more.
That was an excellent presentation, sir. I think the pearls of wisdom on ML, machine learning, and your initial experiences, the challenges, and also thanks for mentioning about the scientific papers and the lack of proper, consistent training data sets and expert data sets, because when you teach machines, it has to be uncorrupted truth and with a positive, with a collateral ground truth. And in TBI, of course, as you have very clearly mentioned, it's a multimodality, multi-parametric approach, both structure, function, and also multiple time points data sets. And I wanted to ask you one very important question, that the moderate and severe TBI, of course, is handled by multidisciplinary teams. But when it comes to mild cognitive deficit and also mild TBI, what are your comments? And that's where the both structural and functional MR and other imaging modalities are actually competing with each other to establish a solution architecture. Please kindly give your experience in this mild TBI.
Thank you, Dr. Vadapalli, for your expert comments and for the excellent question also. Mild TBI, is a Pandora's box, which we have not explored fully. And as it is the base of the pyramid or the chunk of the head injuries which come to any institution, I would say 90% of all TBIs are mild TBIs. So that's a huge number of patients. And although structural imaging like CT or MRI may not show any obvious changes, patients are functionally, disabled. They might have long-term memory loss, headaches, and other symptoms which we constitute what is known as a post-concussion syndrome. And both things are similar, the concussion aspect as well as the post-concussion syndrome. They constitute a very big entity which has not been understood properly. Although a lot of research is going on, we feel that AI and ML can have a huge role in identifying a subset of patients which may be at a higher risk of functional issues following mild head injury. The second point is that although structural changes may be missing, a lot of times functional MRI shows changes which correlate with the patient symptoms. And I think the biggest challenge in these patients, because I have also done a lot of research in this kind of patients, the biggest challenge we face is lack of baseline data. So we don't have any baseline MRI or CT done before the injury, because obviously it's like a population screening model. Unless we screen the whole population, have a baseline data, we will never get to know when the patient is going to have a head injury. So the first scan is always done after the injury. And it is a poor baseline because obviously the changes which are supposed to happen functionally and structurally have already happened. So to actually see the temporal course of these changes, whether they evolve or whether they improve, is like seeing a movie midway. We do not know what happened previously. And I think here again, AI and ML can help, because just by seeing the temporal course, we can maybe derive using surrogate markers what was at the initial time point. So it is an extremely exciting and interesting field. And we are sitting at the cusp of transformation in terms of our understanding, especially in concussion. And I think the biggest, I would say, the asset in these patients is having a data set. As you rightly mentioned, having a large data set can help us find those clues, which, right now in the world, we are talking about data sets having 100, 200, 300 CT scans without any clinical data accompanying them. or the temporal course or the outcome. So if we combine the three, I think the answer lies in having a clinico-radiological scoring system, AI which uses both aspects, right, rather than purely looking at only the radiological data. This is the future where we would be able to help these patients better.
Since this data forms the backbone, I think the protocol also has to be standardized across the institutions and across the centers of excellence, because it is like for a Hollywood movie, you take multiple retakes, but for us, there's only one take. That is, the patient is in the magnet. So we need to put either like a 3D volumetric sequence plus a resting state FMR, which is just to, because of the accelerated imaging techniques now takes only 3 minutes. Of course, the post-processing is a little cumbersome, but thanks to the ML techniques now, the 23 pre-processing steps have been reduced to only 4 pre-processing steps. So resting state fMRI, then cortical parcellations, all these things can be done later once we acquire the data. So the data acquisition itself across the multiple centers, we need to put a very comprehensive neurotrauma protocol where you can acquire the data, because after 3 years, somebody can develop an algorithm which will actually extract a lot of texture features, a lot of, as you rightly mentioned, the data, because unless you have multiple decision trees, random forests, and then the deep learning layer, contextual layer. So the machines mature, and we can actually discover hidden gems of information within it. As you beautifully also made a statement that the data has to be, the quantum of the data has to be good. So I just, to open it for all the audiences, I just wanted to say that the TBI and all the neurodegeneration disorders, including MS and AD dementia, and also epilepsy, all these guys, the burden of a disease is only the atrophy calculation. But apart from atrophy calculation, there are a lot of other biomarkers which are evolving, like brain iron signatures, how much brain iron quantification. So as he mentioned, Dr. Deepak, because always I see him lecturing in NSI meetings, is always very novel and is a very out of the box surgeon. I mean, not a typical surgeon. So he has a lot of creative surgery. So I think we are sitting on a cusp of exciting journey. So now the forum is open for questions, and we would love to answer.
Dr. Ram Mohan, I would just like to add to the point you made that, standardizing the image acquisition is extremely important. However, at the same time, it is very challenging, because I can give you our own example of AIIMS New Delhi. We have the radiology department is into multiple, divisions. Neurology is separate, cardiac radiology is separate, main radiology is separate, trauma radiology, and they don't talk to each other in the sense, in terms of machines. In fact, we have 5 packs running in our institution separately. And because everybody is so paranoid about the data, they do not allow the packs to also communicate with each other. So
I think the passions should converge, sir.
Yes. So I think it is the end user which drives this, and we finally managed to have not 100%, but now 75% of the images end users can access. Radiology departments cannot access, but the end users, clinicians can access across AIIMS. So I think again, time is very important. Over time, people are getting more and more used to the idea of collaborative research, and as I said, these are transformational times, and over the next few years, I think India is going to be at the top in terms of using AI and ML for diagnosis as well as research.
Sir, I am closely associated and work with the Edison AI of the GE Healthcare. So multiple global international startups which are, so definitely I will keep this in mind of your large data set and definitely introduce some of the, the new exciting products to you, and so that you can continue your wonderful research. Of course,
Yes,
NeuroShield have been
absolutely.
associated from the inception. The NeuroShield have been associated from the inception. They are slowly evolving from, in a very, with good humility, that they are evolving from just atrophy calculation and quantification and parcellation. In fact, this RSNA we are presenting the hippocampal, subfield mapping, because I work on epilepsy. So, and then postoperative outcomes. So they have a very good neurocomputational team.
Yes.
So, and it is a pride of India, and I think first of its kind. So please, we should, people like you at the cusp of the research should give you blessings, and also show them the directionality of the cutting edge research.
Absolutely. I totally agree.
Yes, sir. And audience, please ask your questions. And Rajesh and Hussein, please look at the chat box and articulate the questions so that Professor Deepak and...
Yes, thank you, Dr. Ram and Dr. Deepak for your comments and your wonderful presentation. I'm sure the audience is enriched with all of the information and guidance that you're providing them. Doctor, we have a question coming in from the audience. When it comes to use of AI and ML in stroke, what is the low-hanging fruit that one should look at, and where is it that we should focus first in terms of usability and in terms of ease of development of that particular algorithm? Usability for the patient, number of patients also matters when it comes to which algorithm we should develop first.
No, that's an excellent question, Rajesh. And I can tell you there are a lot of low-hanging fruit which we can access. As I mentioned also, see, one of the most important use case scenarios for neurosurgery is a patient comes in around, say, 80 years old, massive stroke, hypertensive, BP is 200 by 120. That's a routine story we get. And there is a lot of mass effect, raised intracranial pressure just by seeing the CT scan, and the neurologists are breathing down your neck to operate upon him to relieve the pressure. Now, the biggest or the most important thing missing in the picture is the neurological status of the patient. So if his GCS is extremely low, I would say if you see the GCS scoring, the minimum is 3 and the maximum is 15. If his GCS is 4 or 5, a lot of neurosurgeons would not operate upon that patient. Now the problem occurs if you talk to the relatives of these patients and you give them the option, look, because the option is there's a 1 in 100 or a 1 in 1,000 chance that the patient is going to improve. Relatives will hang on to that 1%. They will say, doctor, please do anything possible. We know that our patient is going to be in that 1%. This is a standard, because if you are the patient, you would also. So if we have a way of using AI and ML, and that's very easy by showing that the volume of the infarct, the raised pressure, putting in another few values such as the clinical GCS and the blood pressure, and we can say with 99% or 90% certainty that this patient is not going to have a good outcome. We'll be more confident in giving that advice rather than saying 1%. We'll straight away say that this patient is not going to have a good outcome. We would rather say we would just rather provide terminal care to this patient. That is one use case. The second low-hanging fruit which I see is patients coming with hematomas, large hematomas, again because of hypertensive bleeds, any age group, right from 50 years to 90 years. Now these patients, the problem is for the end user volume calculation. We do a very rough volume calculation using the length into breadth into height kind of thing, and the mass effect. We just do a eyeballing of the CT scan to say how bad the scan is. Rather than that, if we have an objective criteria seeing the volume of the hematoma and the midline shift, other surrogate markers of raised ICP, along with the GCs again, we can come to a better diagnosis whether that patient actually requires surgery or not. Why? Because a lot of these elderly patients, as was mentioned, have atrophy and a huge amount of atrophy. That's why the brain compensates. There's so much space that large hematomas also do not cause mass effect to that degree. So they might get away without surgery. So we are in a better position to predict that this patient might not need surgery to become better. So these are opposite ends of the spectrum where both, and this again has never been addressed. I don't know why, because people are looking at AI and ML with a tunnel vision, seeing that how well they can use it in a different context. But these are the actual things as a surgeon, as a end user, as a clinician, I would like to know. And I would just like instead of tossing a coin and saying, because the neurologists are after you, everybody wants something to be done for the patient. It may be good or bad, nobody knows. But if we have an objective way of saying that this is not good, the STICH trial and all these trials tried to find out, they could not, because they never had the benefit of AI and ML. So, we could really make a good software-based algorithmic approach to these patients in stroke.
Sir, I would like to share with you the interesting part in hematomas, right? So if you look at any hematoma checklist, it's a 3D object, hematoma. So
Yes.
that only surgeon knows, because surgeon looks at the CTs and MRs, the glamorous pictures, and turns back his head to the blood and flesh of the brain, and how the brain gets swollen onto his face, the edematous brain.
Yes.
And to handle it and explore the hematoma is not easy. So he would like to know the prognostication and stratification. As somebody asked, the low-hanging fruit would be, if you can predict the hematoma margins, that which hematoma is going to dissect and going into the ventricles and which hematoma is going down, because many times on CT scans and MRs, we don't give that information. When your imaging modalities become surgeon friendly, because I go to more surgeons meetings and clinicians meetings, because I know how much I am under in delivering. When I hear their stories, I want to add in more value to them. That's where ML, and because this hematoma checklist, I am working on that. Because the clot retraction halo or ring around every hematoma in the first 24 hours, wherever the ring is not fully formed. Suppose if the ML guys can give you a clock face superimposed on the image with the visualization. So you say that 3 o'clock, 9 o'clock, or 3 o'clock, 2 o'clock position, the clot retraction is not formed. This is the area where clot is going to expand and hit the third ventricle or go down to the hypothalamus, and patient may deteriorate in consciousness. These are some of the longitudinal story of a patient in the ICU or the neuro ICU. So because the low-hanging fruit word is interesting from the business perspective, but from clinical perspective, as Dr. Deepak correctly mentioned, we should offer the low-hanging fruits. And imaging actually shows you a lot of data, and which data has to be taken into significance and visualization of the data, and from the surgeon point of view, and also the predictions of how a particular patient is going to deteriorate or not deteriorate. And then the decompressive craniectomy in patients with stroke, and in relation to the symptom checker, in relation to the cognition and GCS scoring, if they can be integrated into a dashboard and show a visualization plot, and with the community statistics, patients' relatives will see that, and they will go to denial to acceptance, acceptance to denial. So because I have seen with my own eyes, after CT angio came for the coronary arteries, in the beginning, patients used to make a big fuss for, coronary artery bypass grafts. Now, when I show them the 3-vessel disease and the CT angio with all those visualization, 3D visualization, patient says, yes, I'll get my bypass done, So as Deepak mentioned, the relatives and family members are so anxious that 1%, that 0.5% chance. It's not the greed, it is a chance. It is the ambition. So first they will say, if he makes it for 2 days, it's fine. But then after 2 days passes, then their hope increases, right?
Yes.
But we as a neuro community know that the challenges, as we see every CT, every MR, or as we see the clinical condition, and as a neurosurgeon, he will visualize what benefit to risk ratio I have to offer to the patient. Right? So if that risk analysis and that survival analysis can be plotted beautifully with the images, with a graphical visualization, with a scoring, and with all international guideline scorings, that would be a low-hanging fruit in both stroke and hemorrhage. Thank you very much for this wonderful question, and thank you, Deepak, for your fantastic clinical answer, which is the pearls of wisdom. Any more questions, please, ladies and gentlemen?
Thank you, Dr. Ram and Dr. Deepak, for your response. Another question that we have is, sometimes brain scans are clean, but the patients have symptoms. How is diagnosis carried out in such situations? And what would be the procedure for surgery, and how can AI help here?
That's also a very relevant question, Rajesh. And see, if we talk, as we talked about minor head injury and concussion, that is one entity in which a lot of times, if not all times, the brain scans are clear. And the gold standard for diagnosing patients with this condition is clinical. So if the patient says he's having symptoms, it means that he has a problem. So that is the gold standard. And obviously we can do a lot of functional imaging to find out if there are some areas. But as I mentioned again previously, the baseline scans are not available to make a proper, model on this. The other scenario where brain scans are normal is, any other brain condition. For example, even a small stroke or something else happening inside the brain, where the patient has a problem, let's say a severe headache, brain scan is absolutely normal. Now, the question again is, clinically, because we always consider the clinical as the gold standard, we assume there is an issue going on. So, from a neurosurgery perspective, I would start thinking whether this patient has raised intracranial pressure, because it is not seen very clearly on any imaging. And I would like to rule that out. So that you can use a lot of other techniques, like put in an ICP monitor or do a fundus examination of the eyes to see for papilledema, or you can do specialized CSF flow studies to see if there's a block, or a lumbar puncture to actually measure the pressure. So we have various ways in which structural imaging may not pick up, and intracranial pressure, raised intracranial, is one of the most important in these cases because of any cause. It could be because of vascular disease, it could be because of vitamin deficiency, or it could be idiopathic. Idiopathic intracranial hypertension is a very common entity for this, which there is no known cure also. The only thing is we do a symptomatic treatment by putting in a shunt. But before that, again, for diagnosis, we use all the methods which I just mentioned.
And one more comment is that many times when a patient is found on the road unconscious, people assume that it is a head injury, but he may be having a polytrauma.
Yes.
Multi-organ trauma. So I think that examination approach to trauma, dedicated trauma teams, sometimes if there is no dedicated trauma team, they may miss some internal abdominal injury or other musculoskeletal injury, which can later be discovered to our embarrassment. Especially the injury to when the combination, which is the deadly combination to the brain and the chest. So the chest injury with the lung injury and concomitant brain injury, both can be double jeopardy to the patient. So your comments, sir, your experience in that.
I totally agree. I can give a personal example which I have seen. There was a patient which came to our emergency, and because it's mandatory in the medical legal papers, the doctor had written that the patient was completely smelling of alcohol, so query alcoholic intoxication. And I'm just talking about the reverse. And so a lot of times patients who come with this alcoholic intoxication, they don't do anything, just let them wait for an hour or so, 2 hours or so. And valuable time was lost. So patient GCS kept deteriorating, and after 2 hours, the CT was done, which showed severe head injury, and then we operated upon it. And fortunately, as luck would have it, the patient improved and we could discharge the patient after 1 month. So I asked, I was a resident at time, I still remember, and I asked the patient, why do you drink so much? You should go for de-addiction for the drink. So he says, doctor, I have never touched alcohol in my life. I was on the road on my cycle when a truck came behind me. And because he could not move ahead of me, the driver and the helper jumped out and they hit me with the objects, dumped me in the drain and poured alcohol on me. So one of the biggest lessons we learned at that time was, don't be a judge. You don't judge people by their appearance or smell or anything like that. You have to treat everyone like you would, any person would come in. You have to do the ABC examination, get the things, structural things out of the way first before you start thinking of any functional things. So that is rule number one. Always, always, always first rule out all these structural changes which can happen from the brain top down, and then start thinking, okay, this is non-structural, it could be a functional.
I think there is a comment by Dr. Seema that the question is broken down. Can Hussein help you with it?
Yes. So the gist of it is that this gentleman met with an accident and suffered a concussion, which was of grade 2. And the doctor, at the end of 3 days, that the scan was not required, MRI scan was not required. When it comes to grade 2 concussions, do they lead to any kind of long-term effects? Should we be concerned, or should we, do scans periodically?
Well, that's a very good question. Actually, everything depends on the patient's clinical condition. So as I said, grade 2 concussion, almost 20% of these patients may have post-concussion syndrome or issues later on, which may last for months to years. So if the patient has issues, if the patient does not have any problems like memory disorder, headache, or concentration, then nothing is required. Because if you over investigation is also harmful. But if the patient has symptoms which are not resolving within a defined time frame, time frame depends, because lack of protocols, there is the institutional time frame in place. There is no standardized time frame. I would wait for at least a month in all these patients to see, because 90% of these patients resolve within a month. If within a month the symptoms do not resolve, I would definitely get a structural as well as a functional MRI at that time to see what is going on.
Thank you, doctor. And I hope, Dr. Seema, your question is answered. Doctor, another question that we have is, when it comes to the situation of healthcare services in India, when you talk about the golden hour, it is quite common that when the patient arrives at the hospital, the golden hour is already passed, and at least in India. And what are your comments on using CT or MRI as a primary tool for diagnosis when it comes to stroke?
Again, a very, very good question, Rajesh. I must commend you on your quality of questions. See, in India, as you rightly said, the people come after days, even after weeks, of trauma. And what we teach to all our students, because we've seen it firsthand, is the golden hour starts from the moment the patient enters the hospital. See, you cannot take care of the things which are not under your control. If we can improve our own house, in the sense that we can improve our own care inside the hospital, patient wait in the casualty, in the emergency for hours together before they are seen, and then also they're not taken care of properly. So for us, the primary aim is, as soon as the patient enters the door of the hospital, the golden hour for us starts there. We have to ensure that even if the patient injury might have happened 3 days back, 5 days back, we do everything as we would do as the patient has just got injured. So we immediately get all the CT, and that is what we are teaching, because it is, I don't know how it happens, but we have seen it many a time, that if the patient comes, let's say after a week, he will deteriorate in the next few hours in the hospital. Very common. So they might somehow manage at whatever compensation the body is occurring at for days or weeks outside, but as soon as they enter the hospital, deterioration chances escalate exponentially. And that is why we have this mantra that your golden hour starts within the hospital. The second part of your question was the role of CT and stroke. I am a total proponent of having CT ASAP. We actually, maybe you don't know about it, but at AIIMS Trauma Center, I was the one who first got the mobile CT scan done for our neurosurgery patients, and we then purchased another mobile CT scan, which is there now, 2 mobile CTs in the neurosurgery ICU. And seeing our use case scenario, we got another mobile CT for the main neurosurgery. So in neurosurgery ICU itself, in AIIMS, we have 3 mobile CT scanners. Can you imagine that? Neurology is a more laid back specialty for some reason. And there's a difference in the, I would say, in the people who go into neurosurgery and then go, or those who go into neurology. So that defines the specialty. So we are extremely aggressive. And I was actually after them that you should have a mobile CT in the emergency itself. Any patient with suspected stroke, first put him through the scanner, then do anything else. Because your golden hour starts from the time the patient is there. And if you can save that 5 minutes, because I have seen, even at AIIMS, which is the apex institution in India, it may take hours to get by the time they decide, the neurologist comes, they say order a CT or an MRI, and then the thing is done. So that period of 6 hours or 3 hours for giving any anticoagulation or anything is lost. So I feel they should be, institutions like AIIMS should be extremely aggressive. They should show the beacon to the rest of the country and to the world, and rather not be the same as every other hospital is there. So I think it is a matter of time, it will happen. But I'm a very, very strong proponent that, I would even say that you should have an MRI also within the emergency. Instant. Why not?
Yeah, why not?
These things are there. And you have mobile MRI also coming into, in the US, they already deployed mobile MRI. So why can't AIIMS have it? Every patient. I changed the strategy at AIIMS Trauma Center, because previously, there were all kinds of rules. The rule of 7, head CT rule, when to get a CT done for minor head injury. I said, just forget everything, get a CT for it. Do not, if you start working at a, reflex level, then the system should be independent of the individual. So rather than having a junior doctor decide whether head CT should be done based on some criteria, you say every single patient coming into the emergency where you even suspect even 1% that this patient has a head injury, get a CT done with cervical spine. We made it a protocol. So although radiologists were very unhappy because the head CTs went through the roof, we are doing more than 30,000 head CT scans a year in trauma emergency at AIIMS. So it initially they were furious. Then they saw they realized that they could use that as an excuse to buy more head CT or more CT machines. So
actually, when a pandemic like in COVID, everybody gets a CT test done. Head
Yes.
injury is more important, more paramount importance.
Absolutely.
A high profile importance. And as you rightly said, we should aim at platinum minutes than the golden hour. Because at least when we say platinum minutes, people will fall for the golden hour. When we say
Yes.
golden hour, it will be brass or silver. It will deteriorate in its quality. I
You
totally agree.
absolutely
It is
nailed on
better
that.
to get imaging as the gold standard and fast ASAP kind of protocol. In fact, in Sri Lanka, I used to consult them. We formed a ASAP protocol. That is a fast action stroke protocol as soon as possible. So moment patient comes first, and you know whether it's hemorrhagic stroke or a ischemic stroke. Then you do the fast 8 minutes stroke protocol on the MR. Then we realized as the stroke evolution and stroke treatment progressed, they have relaxed the rules of 3 hours to 6 hours. And then slowly, the diffusion perfusion mismatch and everything. So the stroke team in the beginning used to really put us to test. Say that
Yes.
fastest 8 minutes protocol. Then on the stroke table itself, on the MR table itself, there were emergency physicians, stroke physicians who used to give RT-PCR. But the thing was that many times there are a lot of contraindications. So
Yes.
then you will know the field reality. Because
Yeah,
that's why I keep telling from the PPT to reality. When we show them, when we show PPTs in the talks and sensationalize the audiences, but when it comes to real practical game, we have only one take. And as you rightly said, give the best benefit to the patient. And whatever rules we form, you should not be for the comfort of the organization, it should be for the comfort of the patient. So we should have a patient-centric rules. I totally agree with you, sir. So any more questions, Hussein and Rajesh?
Yes, we have another question. Doctor, first of all, a second part to this question and then followed by another question. I know we are running out of time, but I believe in the way of science, we can give a 5 minutes extra. So how can AI help in this context when it comes to the golden hour or the platinum minutes? Could it be abnormal flagging, or could it be faster scans? What are your inputs on this?
See, if you talk about flagging, AI and ML can be used at various levels. It doesn't have to be only at imaging, So if you're talking about AI and ML and imaging, that's a separate thing. But if you talk about AI and ML in general, then we can start flagging right from the time the patient is seen by the initial triage nurse or a doctor and his symptoms entered into the case record or the medical legal. As soon as the symptoms and signs are entered, the AI and ML can take over and give a probability diagnosis that this patient is a high risk of stroke. We should get the CT done ASAP before anything else. So before even the neurologist or the neurosurgeon come into the picture, CT should be done based on the AI recommendations. So this is again a very low hanging fruit, obviously non-imaging, but huge role to play in the initial triage and management of these patients, where patients keep waiting for the specialist doctor to first see and then decide or to have a CT scan or MRI. So that's number one. Number two, if you talk about imaging itself, so during imaging, again, if it is the volume of the stroke, there's so many parameters which sometimes clinicians are not clear whether we should go ahead or not. Again, AI and ML can help in those conditions to make a more definitive, decision making in these cases.
And also they can add quantitative indices and reduce the subjective bias, make it more objective. Yes. Number one. Number two, please understand that head injury is a traveling variable in the sense that the patient is in the ambulance, patient is reaching the hospital or from a primary care to tertiary care hospital. So the treatment and the modalities and everywhere AI and ML algorithms will make a lot of difference. So the first three things to be done automatically, the ambulance, the emergency responder in the ambulance, what he has to do, what he should not do. If there is a concurrent spinal injury, how to position the patient, how to make the patient lie down. Because as sir has mentioned, the craniovertebral junction I'll tell you a lot of stories, challenging stories, because a guy on the scooter falls into a big pit, and the guy who is driving gets a head injury and has contusions. And the guy who is sitting on the back, he has a little neck pain. So the radiographer does the radiography. So the clinician says that get a neutral to know atlantoaxial dislocation, to see the flexion, extension, and hyperextension. My rule is first see in the neutral position. If there is a gross dislocation only, then you do flexion, and then you don't do. With a gross dislocation, because if you do any kind of manipulation of the spine, you will land into trouble. So many times there are collateral, non-obvious, and more dangerous, things happening parallel. That's why the whole journey of the patient after head injury and stroke and TBI, every point of care requires AI and ML algorithms, which have to be mapped. And then it's not just imaging; it's the whole story of the patient. Then the outcomes will be definitely impacted. Yeah. So the golden hour is not only just when the patient walks in, platinum minutes, when everything has to happen in that framework at the right time. And the team or the task force which is acting in the neurotrauma, all of us have to be have NI, that is natural intelligence first. So our NI should work, then we can get AI also. So we should first exploit NI and put all our protocols, then take AI as our assistant or Watson to the Sherlock Holmes edition. Yeah.
Thank you so much, Dr. Ram and Dr. Deepak, for your inputs on this. One final question before we close for the day. Initial conservation or conservational treatment or early surgery, which one reduces major disability in patients after stitch? Your comments.
This depends on a lot of factors, where let us put this question on a stronger, footing, in the sense that let's put it where there is clinical and radiological equipoise, whether we should go in for surgery or conservative, what will lead to a better outcome. So when there is equipoise, I think it is always better to err on the surgery side, because conservatively means not doing anything, and patient might improve, might not improve. So we have to remember that head is like a pressure cooker with no vessel. So there is no outlet. So if the brain swelling occurs inside, the brain will cook inside itself. There is no way to save that brain. And neurons are something which do not regenerate, and it just takes 3 minutes. So for the neuron to die once the pressure is high enough. So we as a neurosurgeon, we believe the GCS score is good. That is very important. And there is clinical equipoise and radiological, whether we should operate or not. We give the benefit of patient. Always, we try and give the benefit to the patient, so that, at least we have removed the hematoma, the part of the skull. So there is no question of raised intracranial pressure having a deleterious effect, and outcome may be the same or better. Obviously, there are complications because of the surgery itself, but in today's modern era, they are very, very less.
Thank you, Dr. Agarwal, for that response. And I would like to thank Dr. Ram and you for taking the time to join us today and share your wisdom and experience with the audience, taking us closer to a safer and healthier tomorrow. Thank you so much for your time, and we are humbled and honored to have you.
Yeah, Dr. Deepak, once the corona effect ceases, I'm going to meet you in person, and we'll have an offline dialogue and how to take it forward, sir. Right?
Definitely, that I would love to go. I'll take you on that. Thank you so much.
Yes, sir.
Thank
on
you,
behalf of, and also since I work closely with GE Healthcare, they have been looking at collaborating with you, and wonderful applications, and so I will come and see you in person. Because
Definitely.
I think the most important parameter of a person is passion. I think if the passion is missing, no matter whatever AI, NI you have, all the algorithms will not touch the heart of the patient or will not touch the lives of the patient.
Yes,
Thank
I
you very much, sir. Thank you very much for your wonderful talk and your wisdom, and all the best. Thank you.
Thank you. Thank you, sir. Thank you.
And my special thanks to NeuroShield. Keep growing. All the best.
Thank you, Dr. Ram. Ladies and gentlemen, we look forward to seeing you in the next webinar. A link to the YouTube recording of this webinar and all previous webinars will be sent to you via email. Thank you everyone once again, and have a great evening.